Hello there. How's it
Hi,
going?
it's going great. Good to see you.
Yeah, great to see you. I know I haven't seen you, I feel like since we were collaborating together on an old project that we're not going to talk about today. But I'm always so appreciative of your time and space because every time I feel like every time we talk, um there's a lot of things that we get to touch on because you're so creative. And I have to say, you're probably the most creative student I've ever had. So, and also very compassionate, like just good-hearted person. You're a good people. So I appreciate you being here today.
Yeah, thanks, Dr. Mello. I really appreciate that.
Uh,
It's been a long time.
yeah. And so, if you all didn't see the post to introduce Jasmine, Jasmine is a PhD student. And I guess I'll let you tell more about like what you're studying as a PhD student.
Yeah, so I'm a fourth year, can't believe that, PhD student at Georgia Tech in human-centered computing. And my research is broadly in the space of something I'm calling technology-mediated violence. And what that means for me is that I'm inviting the field of human-computer interaction to take a more cross-disciplinary approach to how they think about violence. And that is historically, we've just used terminology like consequences and harms when it comes to understanding the role of digital artifacts, media, social media, for example, different types of tools in harming individuals and communities. But that language keeps us pretty divorced from the different fields of study and practice that actually work on prevention techniques, such as public health or criminal justice or social sciences or even the humanities that try to have this a more comprehensive idea of violence. Um, so I expand that idea, and then specifically, my work focuses on the structural violence that can be amplified, created, or reduced by different types of technology. And by structural violence, specifically, I mean the silencing of oppressed and marginalized groups that keeps them from ascertaining optimal quality of life and preventing injury and death.
Wow, that was very jam-packed. And very important. I mean, this is a very complex matter. Um, at because like you're talking about the intersection of so many different issues and concepts here. And I guess I'm gonna step back a little bit and how did you even come up with this kind of project? Are you in public health or were you in public health?
Yeah, so my background, my academic background is in public health. I got my master's in public health from the University of Southern California. But while I was there, at the time, injury and violence wasn't a core part of the curriculum for a public health degree. And I happened to be working in parallel at Grady Memorial Hospital doing violence prevention research and practice. And I noticed that like the electronic health record was central to the kinds of things that we were developing and how we evaluated outcomes and things of that nature. And the electronic health record is this really interesting place that's like full of really rich data, but the way that data comes back out of it, I would say was partial. There were partial pieces of the realities of lived experiences for patients, but that data that was exported heavily informed research publications and operational decisions within the healthcare system that just reinforced some of the harms and challenges faced by the population that my safety net hospital served. So I wanted to really address that after working for about 8 years and seeing the challenges. I think that somebody needed to bring kind of a light to the role of systems like an electronic health record in modifying to the detriment of certain groups the narratives of health and harm.
Wow. So when you talk about this, you felt that you were only seeing partial data. Can you tell me more about that? It sounds like you're saying there's some missing data there. How did you, were other people? saying the same thing, or it was more like, wait a second, like something is missing here. So I wanted to know more. Can you like describe us what that really means to you, or how you came about determining that no, there's something else is missing here?
Yeah, happy to. So this idea of missingness for me has evolved a little bit over time, as I've done a bit more research, but the primary example that I have that really had me thinking about like, okay, there's actually a lot of important information that we're not getting access to that could help us prevent violence and injury in the future. And it was through my work on the translation of the Cardiff model for violence prevention in Atlanta, which we did when I was at Grady in partnership with CDC and the DeKalb Police Department, which basically the model collects violent injury information from patients when they come in the emergency department. It de-identifies that information and then combines it with law enforcement data from the same time to discern which of the incidents were reported in the emergency department but not known to the police. And that's important because criminal justice data heavily informs funding and priorities for violence prevention strategies, especially here in the United States, because the institution of the police and how they function. And what we learned when we implemented here is that between 80 and 90% of the incidents that were reported in our emergency department as happening in the county we were partnering with were not known to the police in those jurisdictions. People don't trust the police, right? But maybe they trust their healthcare providers. And prior to implementing that model, we would never have known that those people had violent injuries, right? Because they weren't severe enough to be trauma patients, but they had experienced violence and therefore were at risk for future violence. And just by asking the right questions that had not been asked before and privileging that information, that part of the story, we're able to elucidate so much valuable information and act on it, right? To hopefully for the betterment of the communities that we serve. So I've just kind of taken that thread and run with it in my research.
Wow, wow, that's amazing. I guess, I've never used that model, so I'm not as familiar. Um, and we're talking about missing this. So I was just wondering, um, with the data that was run in those models, did they ever collect data from like the patients themselves?
Yeah, so the information was collected directly from the patients. And these aren't computational models. It's more like a public health model for violence prevention, like a practice framework. But patients will come into the emergency department, and as a part of their triage process, we train the nurses to ask, what brings you in today? Are you injured? And if you are injured, was someone trying to hurt you when you got injured? And if they say yes, then we ask more questions, right? So tell me what happened. Was there a weapon involved? And where did this happen? Did it happen in a public space or was it in a private residence? If it was a public space, say like a bar or restaurant or on the street, we try to get as much geographic information, geolocation information as we can. So that would be either intersections if they don't know a physical street address or a business name. Um, and then we use that to map the violent injury and the time against the law enforcement data. So it the whole model only functions if you have that primary data collection directly from the patient. That's the bread and butter of it.
I think that's pretty cool. Because then you have this clinicians and practitioners basically doing data collection. And so did they have to be trained for that, or did you get any pushback from? They're already very busy people, so I can't imagine they're like, you want me to do one more thing? So I was just seeing like what how did you get the buy-in from these practitioners?
Yeah, that was one of my favorite parts. It was actually the whole of my responsibility for that project. And you are absolutely right. It there's because of the size and magnitude of the electronic health record, the PI, Dr. Daniel Wu of the project, said that the nurses had become screenatologists, right? Instead of getting to do their nursing practice, they're just clicking buttons and typing things in, and that's what makes the whole process go. And it's quite a bit because they want to be at the bedsides with their patients. So Um, there was formal training. I condensed my in-service training for nurses one-on-one or in staff meetings down to 7 minutes, right, to minimize the amount of time and attention I needed from them to understand how to use the screen that we designed and implemented in the electronic health record. And then I stayed engaged, right? We created lots of like support materials. So we had like little cards, we call them badge buddies, that reminded them of basically the script for the screen if they forgot. We also, nurses love pens. So we got them this like a pen that rotated the questions through like a little window, which they all loved. And then I became known as the candy lady because I had this white bucket that I always carried with me across the shifts with snacks and things like that, just to talk to them about like, hey, how's the screen going? What's working for you? What's not working for you? What's come up? Um, and so that was just a great way to keep everybody involved. The screen wasn't mandatory, but we had over 75% compliance rate by the time every nurse on staff had been trained. And we completed a satisfaction survey with the nurses in which the nurses were excited for the screen, right? They were excited because they learned a lot more about their patients, which they wouldn't have if they didn't ask. They then had more questions, right? Like, now that I know this about my patients, who do I talk to? Do I get social work involved? Like, who can support my patient? Now that we've surfaced this information, they felt like the screen aligned with the mission of the organization, and they felt like we had designed it in a way to fit well in their workflow. That is, if they ever clicked no at any point, the screen stops because we don't want to ask you to collect unnecessary information on a patient with a stomach ache, right? They're not there for violence. So these are things that they all appreciated, and it kept the screening rates high. I will say that COVID really shifted, right, everything in emergency departments and hospitals across the country. And so there's a national network for this program now. And all of the hospitals are facing similar challenges with keeping screening rates high. And we're starting to look for other potential avenues for patient reporting. But at the time, people were really enthusiastic about it and they made it a priority in the way that they cared for patients.
Wow. Well, congratulations on that. And thanks for your service. I mean, you're helping the patients, but you're also helping this like clinicians and practitioners um, get engaged in this work that they didn't have to do before. And so I guess this experience, because you said you were here for 8 years, how has this, I guess, influenced or impacted the way you think about your current project?
Yeah. So, one of the most interesting questions I got shortly after starting my PhD was whether or not I am like, uh, I want to abolish certain systems or I want to reform them. And it's something that I keep trying to figure out, right? Because you could see that my experience with translating the Cardiff model was a positive one in which we like reformed the triage process, so to speak, in order to help patients towards preventing violence, right? But my work, my research now, and the way I think about missingness and data really takes the position that institutions of healthcare, the criminal legal system, and public health have perpetrated historic harms against oppressed and marginalized groups, right? And they are the structures with like from which those groups also have to derive any opportunity at improved quality of life or prevention of sorts. So um, I want accountability from those systems, and I use data in such a way to surface information that would otherwise be hidden in the way that like oppression and silencing can be embedded in the function of healthcare or criminal justice. Um, but I'm surfacing it for the purposes of like changing the technologies used in those systems. And so like I'm starting from a place of like accountability, institutional accountability and potentially abolition. Like it's inherently harmful what you do and how you function as an institution against these groups. Um, but I'm going to use what I find to change your technologies. And I think I'm still navigating that. It's not even completely linear for me. Just because like I think that's the state of the world that we currently are in. If we eliminate healthcare institutions, then we just have more problems for more people. But I also what the Cardiff model implementation taught me is that like we can go beyond trying to make our police officers or our providers less biased and less racist and actually fundamentally change the tools through which they amplify and enact that bias and racism, and kind of disempower some of those levers in a way, but not because I want to save the systems, but because I want to support the people who are forced to interact with them. Uh, I hope that answers your question. I realize I was a little bit on a soapbox.
No, again, this is about you and your thoughts. This is already the second or third time you've mentioned this notion of silencing or muting. Can you tell us a little bit more about that? How does that look like in the data space?
Yeah. Okay. So I guess I should tell you what muting is first when I say that. So when I say muting, I'm referring to an anthropological theory called muted group theory that was created by Shirley and Edwin Ardner. And it has four main ideas. Well, basically, its focus is on the processes of domination and silencing in communication, between dominant groups and non-dominant groups. So the four main ideas of this are first that group membership or identity is socially constructed, right? Gender, race, all of these things socially constructed. And the mechanism through which these things are constructed, this is the second idea, is communication in the public discourse, right? By the way that we talk with each other and share our experiences, we're socially constructing our realities and therefore our identities. Um, the third idea, though, is that non-dominant groups therefore have to use or adhere to the communication norms held by dominant groups in order to have their concerns and issues heard. Um, so if I want my doctor to take me seriously, I have to say the right words. And you may have observed in your own use of social media lots of people telling other people in the comments what test to ask for, what thing to say, what terminology to use in order to get the outcome that they need from their providers because they otherwise go unheard, misdiagnosed, etc. So that's a great example. The fourth idea, though, is that collective communication can be leveraged to affect social change. And my favorite example of something like that is the neurodiversity movement, right? And how so many people, how social media and its functions help to make visible so many different varieties of neurodivergent lived experiences that people were then able to normalize their own experiences and seek the supports either through diagnosis, medication, or like behavioral accommodations that they needed to make their lives easier. Just by overcoming the marginalization and fragmentation that happens when certain groups control the discourse and whose thoughts, ideas, and experiences are valid. So when I say muting, I talk about the mechanisms of silencing non-dominant groups that keeps them from accessing information or resources that would otherwise allow them to obtain a higher quality of life.
Wow. Wow. Thanks for breaking that down. Actually, when you were talking about it, it made me think of a recent publication that you have. Um, because even though the muting is happening on the systemic level for well, you can talk more about it, about your article on this, how the reporting of suicide, is that correct?
Yeah.
Can you like tell us a little bit more about that? Maybe people want to check out the article.
Yeah. So the recent publication, well, it was recently accepted, but it'll be available in May, I believe, if not a little bit sooner. So happy to share that when it comes out or preprint if people are really interested. So what we took a look at um, is news media. And I kind of try to understand muting as kind of like a cyclical thing. So starting with like how people are able or not able to disclose in their encounters with their providers. And then say you go to your doctor. I tell my doctor my whole health experience, and my doctor decides that only 20% of that is medically relevant. That 20% is the only thing that gets put in the electronic health record. Then it gets extracted and providers or clinicians are using that to perform their research and produce statistically significant results, which then turns into practice and then turns into public perception and opinion, which either gets echoed or manipulated in all of the media that we consume, such as the news. Which then affects, again, how people seek help from their care providers and so on. And so, suicide, we wanted to understand how news media talked about suicide in such a way that might influence whether or how people seek help and support. So, the recent publication involved trying to figure out patterns of suppressing certain stories of suicide um, that would harm certain groups using this idea of this theory of spiral of silence, and that individuals can be a part of certain group of public discourse if they feel that their opinion is not of the majority of opinion. It can influence whether or not they speak out to the point that they are in a opinion, they're in isolation in their opinion. So what we looked at, we queried several thousands news stories for disclosures of suicide deaths. And then we classified whether or not the suicide death had been attributed to a structural circumstance, such as a financial or job problem, an issue of access to healthcare, a school problem, things of that nature. And so then we looked at the frequency of how often right and left leaning news outlets attributed either of those structural circumstances to the deaths that they reported. And we found that there is a statistically significant difference in how frequently right and left leaning articles talk about certain structural factors associated with suicide. And why that might matter is related to the next thing we found. So I typically do mixed methods in my work. So we had this computational approach, but then we looked at each of the articles and performed topic modeling, where we tried to find latent patterns and groupings of the articles based on topic and understand what some of the more qualitative nuances might be in the way that right and left leaning news outlets talked about the circumstances that they did report on. So, for example, in the case of a financial circumstance being attributed to a suicide death, left leaning outlets tend to report on those circumstances in a more systemic or collective responsibility kind of way. That is, they talked about how so many farmers were at risk for suicide after COVID-19 because of substantial financial losses, right? And they talk about it from the space of we have a responsibility to address and acknowledge the implications of this group. Whereas right-leaning articles didn't tend to report on those circumstances at all. They focused on instances where someone's financial hardship could be blamed on them and their irresponsibility. And this is a more isolating perspective. So we have more like collective systemic and more like individual blame. And where that comes into the muting piece is that by intentionally eliminating or suppressing the disclosure of these more collective ideas, right-leaning outlets can perpetuate or form a spiral of silence around their readers because they consume primarily right-leaning media, and they may not see their own financial or health experiences represented in what is mirrored back to them about the rest of society, which can be really isolating and reduce the opportunities for them to seek help or support if they are experiencing any suicidal ideation or depression or other hardship that often precedes suicide death.
Wow. Wow. That is just incredible that you were looking into that. And that's why I also wanted to bring it up because this could be something that people are interested in. So once you have that preprint, we can definitely add that to, you know, the promos for this episode. And thanks for like sharing about it because this is real. I mean, this is like real life. People talk about data like it's like a removed thing, but it's permeating through our everyday lives. And this actually made me think about your research project too. Um, in terms of like the silencing of different of like oppressed groups, right? Can you tell us now more? I know a little bit about your project, but others do not. Can you tell us more about your research project in terms of like this common thread that you're doing? It seems like you're always thinking about addressing this structural systemic issues, um, especially for supporting like oppressed groups. Can you tell us more about your project?
Yeah. So again, I said earlier, I can't believe I'm fourth year and I'm like getting ready to propose and defend, and it's so exciting, but it's so stressful. So I guess I'll just, briefly start from the top of the whole story I'm trying to tell. And the first is, like I mentioned, technology-mediated violence, and saying that like violence can be influenced by our technologies, right? And that muting is a type of violence that can do that. And in my work so far, I've just kind of worked to illustrate that base principle, right? That muting is a type of violence and that our technologies mediate it. And I've been able to um, illustrate a couple things in my publications. The first is that like the removal of important information, such as the news article I just mentioned, is a type of muting that happens in the public discourse and influences, the potential outcome of suicide. And then I've also illustrated the ways in which our technologies or the designs of social artifacts replicate the dynamics that facilitate muting in the first place. So I've talked about those four main ideas of muting. And through some research we've done on disclosures of gender-based violence on Reddit, we find that the subreddit structure design on Reddit actually almost perfectly replicates the structure of dominant and non-dominant groups and whose disclosures are valued and appreciated. And so by replicating those same social hierarchies, we find that what would be a great avenue for us to surface more valuable information about the true burden of gender-based violence and or provide support to survivors online who are choosing to disclose, the design of that system actually silences them more by removing their disclosures, or they experience shame and dissent when they try to disclose in the dominant discourse space. So our technologies also replicate muting. And then additionally, even though some technologies are really well intentioned, they reinforce the issues of muting. So even though in their structure, they're trying to overcome those things, such as the National Violent Death Reporting System, where we have these brief narratives of really rich qualitative information about people who experience violent death, so suicide, homicide, etc. These narratives and the way that they're being used in research are inherently flawed, right? And so when people are trying to leverage this for health equity research, um, like using only epidemiological methods completely excludes context, and that just replicates some of the inequities in information in our research and therefore our efforts to address health equity issues in suicide and violence. Or similarly, a lot of people use generative AI, like large language models like ChatGPT or Claude, to access information that they wouldn't otherwise have, especially in the case of survivors of intimate partner violence or domestic family violence. They may use ChatGPT to ask if they're really experiencing abuse or to understand non-abusive dynamics. And although the intent is for these technologies to provide information that provides clarity, it may unfortunately just reinforce some of the myths and harmful communications around the topic of intimate partner violence that just further disadvantages survivors. Um, so what I'm working towards now that we've highlighted removal, replication, and reinforcement of muting is we want to understand what we can do in design to remediate that. Now that it's visible, how can we address it in the way that certain populations who have really disparate health outcomes, such as Black birthing people, Black maternal health is a major issue for the United States as in the global as a country in the global North, and a high income country. We still have a tremendous problem with Black birthing people dying at almost 3 times the rate of their white peers. So, what is something we can do in design to help overcome the muting that induces stress for Black birthing people in our healthcare system? And how can we think critically about the potential for harm in our well-intended design systems? And so I'm still working through that study, but we're really privileging what needs to be communicated, who needs to hear it, and how we need to respond to it, and trying to embed those principles in anything that we design and or to create a design framework that helps designers do this with the technologies they go on to develop in the future for these groups.
Wow. Wow. That's such a huge problem. I think more and more um, studies are coming out now, and we even have when, obviously Serena Williams was giving birth and still was ignored, and that's like a super famous rich person, right? But because like she's a Black woman, they the providers may not have like taken her as seriously as other um, new mothers. And so that actually made me think about like I don't know. Were you were you a mother, or did you give birth? Like I wanted to know, was there like a personal story behind you, like with going into this specifically, this kind of research?
Yeah, so my personal motivation, not from the Black maternal health perspective, I'm a supporter, and I know lots of Black mothers and parents who um, I have considered mothering, and I also consider the risk of an adverse outcome or death in whether or not I think about having a child. It's a recurring conversation with my own partner and I, but I also know people who have had trouble navigating the health system when they were pregnant and or giving birth, and are actively looking for alternatives to a system. But with the work that led up to this project in particular, I had personal experiences being silenced by the police. So in content warning for some listeners, in 2014, I was robbed at gunpoint while at the home of a friend. And in trying to communicate to the officer exactly what happened, he hardly wrote anything down. He kept referring to my friend as my boyfriend, who's incredibly dismissive. And what he did end up capturing went on to inform a news story in which my identity was completely anonymized, but it informed a news story in the local paper that people engaged with online, in which they, because of the way it was portrayed, were incredibly critical and not at all compassionate, and said that like it was a setup or they knew about it, and all of these things were incredibly harmful and unhelpful. And I can only imagine that the gaps in what he documented from a data perspective heavily informed how effective their investigation of my very traumatic experience was going to be. And I definitely took major issue with that. And I also had the experience of my grandmother who had cardiac difficulties um, later in life, and she was a bus driver by trade, and like that was her only source of income, and she frequently had to take off of work in order to go to her doctor's appointments, in which she regularly felt unheard when she was giving feedback about how the medication was affecting her life or what she thought, her core problems were. Her providers weren't listening to her, and at some point she decided that she'd rather live her life on her own terms. She stopped taking her medication and experienced several strokes and then uh, dementia until ultimately she passed away. And so these are two experiences in which we see where people being unheard or intentionally ignored to some degree by the institutions charged with helping them can really affect the quality or the end of someone's life. Um, and even though I don't think it's reasonable to change the perspectives of any of the personnel in those institutions involved in the stories I just told you, by making the way we collect data about a lived experience more collaborative, by giving more autonomy to the people who are sharing their stories and the way that those broader stories are shaped, we might be able to affect some change by surfacing otherwise hidden or ignored information.
Wow. Well, I'm sorry about your grandma. Um, and we're at time now. And I know I can talk to you for hours and days, because you just have so many, you know, like you're a very reflective person. And I think that's probably why you engage in all this amazing kinds of research. And is there anything else that you would like to share with, people watching about data?
Yeah.
Anything really?
Yeah. Well, I mean, first, I just want to say thank you so much for having me and giving me an opportunity to talk about this. And I hope that as people are thinking about data and trying to understand it more, that they give themselves a lot of space for their own intuition and that they lead with questioning more, right? Data isn't inherently an answer. It's always a partial answer, potentially. It can tell us a lot of things, but it can also tell us something else if we turn it around and we look at it differently, if we interrogate the sources from which it comes from and where it's going and what purpose it serves. And I think that's been the most enlightening thing for me. And I hope to keep that spirit in my research. So I really invite people to start doing that more in their everyday lives.
Okay, great. Yeah. Well, thanks again. And I hope to see you, sometime soon.
Yeah, likewise. Thank you.
You.